Welcome to At Issue. I'm H. Wayne Wilson, and as you've already determined, this is not the studio at WTVP, but instead, we're at the JUMP Trading Simulation and Education Center located on the campus of OSF St. Francis Medical Center. And I'm joined by Matthew Warrens, who is the Executive Director of JUMP Trading Simulation. And thank you so much for joining us.
Welcome to JUMP.
So before we talk about, and we do have some videos to show, but before we do all of that, where are the origins of JUMP Trading?
Sure. So JUMP Trading Simulation and Education Center is a collaboration between OSF Healthcare System and the University of Illinois College of Medicine here in Peoria. It's a unique collaboration that you don't typically see anywhere else in the country, where a large healthcare system and the university are working together to train both medical students and nurses and practicing clinicians to improve healthcare outcomes.
And JUMP Trading comes from?
And the reason that all this was made possible was because of a very generous gift of a family who had a daughter who was a patient at the Children's Hospital several years ago and had a great outcome, and she's healthy and attending college today. And we're very thankful that the family gave a large gift for us to be able to create a center like this.
And the name of his company is JUMP Trading.
Absolutely.
So there are two floors here. Two floors designed intentionally that way?
Yes, so on the first floor of JUMP, we have individual learning labs where clinicians come in and demonstrate their core competencies to perform various tasks. And on the second floor, we've created a virtual hospital where we use simulation training to improve teamwork, communication skills, role clarification. And we do that by repetitive training with deliberate feedback and a safe and learning environment for our students.
And Dr. Lisa Barker is the curriculum director for the virtual hospital.
We have virtual ICUs where we can take care of intensive care type patients. That's what ICU stands for. We have virtual patient units which replicate the floors, is what we call them, so just a general medical floor, general surgical floor. And we even have a virtual operating room where we can simulate surgical procedures, have the surgical team taking care of surgical patients, anesthesia cases, that sort of thing.
You mentioned surgical teams, so is part of this working together as a team, the training to improve communication?
Yeah, that's one of actually the real benefits of what we call immersive simulation. It's been very well reported that communication is the root of many medical errors, and so the communication between team members is an opportunity to increase patient safety and an opportunity in simulation-based education. So we can bring all members of the team together and take care of patients just as we do in the real hospital.
So are these units that you described, the VICU and the rooms, are they positioned in such a way that you can move patients from one to the other and actually see, it's like being in a real hospital?
We have, so for the VPU, which is like our surgical or medical floor, there's 6 rooms all right next to each other. So a patient could become more critical and be transferred to the ICU. If you want to step back, we can even go from the pre-hospital. So I think we talked about the regional transport center. We could bring someone in via the ambulance, bring them to the ICU or the virtual OR, and then to the floor. And even we've done some discharge planning from that point too. So from admission to discharge, we can cover it all.
In talking about patients, that the role of the patient is usually played by a mannequin. How important is the role of the mannequin in the virtual hospital setting?
It'll depend on the educational goals of that simulation. So remembering that all of these technologies are really just tools to get achieve an educational goal. So the fidelity of the mannequin allows us to immerse the learners in the clinical situation. So we may have, if it's the operating room, we may have injuries, there may be blood if it's a trauma. If it needs to be a resuscitation, the mannequin allows us to do CPR and really not just say what we're going to do, but do it with that team performance. But on the flip side, we also have standardized patient actors. So that may be, they may serve the role instead of a mannequin if communication is the desired skill that we're training for.
And you can replicate injuries and conditions and changing conditions from a control room?
Yes, so behind all of the virtual hospital, there's what we call the backstage, similar to the back of house for a restaurant or a theater. And that's where our simulation specialists control the vital signs of the mannequin, whether they're breathing or not. Some of them can change color. So all of those high-tech features are managed remotely from behind the control room to keep the learners immersed in the simulation and not be thinking about the technology.
And then at the end of the simulation, the real benefit comes in the debriefing afterward?
Absolutely. So that simulation experience provides the platform for what we call a learning conversation, where we can talk about what went well, talk about what the team can do better, and how to improve the performance for our clinical care, which is the ultimate goal, to improve patient care outcomes.
One of the programs at Virtual Hospital is nursing orientation. How has that benefited?
Yes, so prior to having JUMP, we were doing new nursing orientation at all of our facilities. And so we have hospitals all across the state of Illinois and even one in Michigan. And now we're able to standardize and centralize all new nursing orientation. So nurses travel to Peoria for an entire week, their first week of employment, and they have several educational experiences here at JUMP, one of them being in the virtual hospital. And this has allowed us to improve educational outcomes for that program.
Let's move from Virtual Hospital to Anatomical Skills Lab. Now, there was an old lab. You actually had a skills lab, didn't you?
We did. We had an anatomical skills lab before. It was in the hospital at St. Francis Medical Center. It was a very small room. It was built probably in the early 1940s. And so we were very excited at the opportunity to build a new lab with all the equipment that we wanted to have, better lighting, video cameras actually in the light so we can film the procedural field and then use that as a teaching tool to show the students how they performed afterwards.
Heather Hopley is the coordinator of the Anatomical Skills Lab.
So our Anatomical Skills Lab is set up to provide education and training for the surgery residents. Essentially, our lab is set up much like you would see over at the operating room. We have surgical stations, and at each station we have a dissection table with an overhead surgical light. The surgical lights have onboard cameras, so we can project what we're seeing under the camera to the monitors in the lab. Likewise, we can record the dissection that we're doing so we can watch it back at a later time for assessment.
Who are the students that are in here and what are they working on?
So the learners in our lab space are surgical residents, both general surgery residents and neurosurgery residents. So they use the lab space here in order to do cadaveric dissection and also to practice surgical procedures on the cadaveric specimens.
Cadaveric meaning from a cadaver.
Correct. So we're using human body parts in the lab.
Do you use animal tissue as well?
We do on occasion, but for the surgery residents, we want their experience here to be as realistic as possible and as comparable to their experience in the OR as we can make it. Therefore, we typically use the cadaveric specimens for the surgical residents.
And the benefit from all this is?
The benefit is that they're in a safe learning environment, essentially, so they can practice their surgical procedure here. They can become competent and confident in their surgical skills. So then when they go over to the OR to actually perform that particular surgery, it provides a safer and a more successful operative outcome for the patients.
In addition to students learning better skills on cadavers, there is the opportunity for manufacturers of equipment to bring their equipment, their instruments in?
Yes. So if there's a medical company that wants to demonstrate a new product or a new procedure to healthcare professionals, they're able to rent our lab space in order to host a workshop, so to speak, and to have the physicians come in here and get a chance to use those new tools and instruments and get a feel for if it's something that they can put into their practice.
The JUMP Trading Simulation Education Center, people have heard the term and they're learning a little bit now about it, but really this is a very unique facility.
Yes, it is. It's probably one of less than a dozen facilities like this in the entire country. In 2011, when we were informed that we were going to get this generous gift, I had the opportunity to go several places in the country and look at what other organizations were doing around simulation. And so we went and looked at some university settings like Stanford and Harvard to see what they were doing in their labs. And we also went to some large healthcare systems like Kaiser Permanente in California, Cleveland Clinic, places like that to understand how they were using simulation. And we came back and were able to design a center that is truly unique, and the collaboration is what I think sets us apart from those other places.
And this was purposely designed as an innovation center of sorts. Absolutely,
because not only are we trying to provide, meet the expectation, but we're trying to raise the bar here. Our goal is to provide world-class simulation and education.
So that's not just a phrase, it's world-class.
World-class, yep.
So at the same time you're designing this, you've got the gift from Jump Trading, and the Affordable Care Act is coming into effect. Impact on you?
Absolutely. The Affordable Care Act really requires healthcare delivery systems to completely change how they deliver healthcare today. And so here at Jump, we're tackling that on two fronts. One is that in an innovation space like this, we're creating new simulation tools and devices to train our clinicians to do things that maybe they haven't done before, and training them to a higher standard or a higher level. At the same time, we may be creating new care delivery devices and testing them in our simulation spaces so that we can teach our clinicians to practice to the fullest extent of their licenses, which is one of the things that we're leveraging to change to the Affordable Care Act.
And let's take a look at that innovation lab. Dr. John Bozanellic is the Chief Medical Officer of Jump Trading Simulation and Education Center.
The Innovation Lab is primarily about bringing engineers in proximity with clinicians. When we bring engineers in proximity with clinicians, we bring remarkable tools and techniques into healthcare that aren't routinely there.
So is the ARCHES program, and you'll have to explain ARCHES, but is that an example of this bringing engineers and clinicians together?
It's absolutely an example. So ARCHES is broken down into some components. So applied research. So applied research conveys the idea that there are technologies that are out there that just haven't been applied to the healthcare context for community health. And so our target is to improve the outcomes of patients in our community and beyond through engineering and simulation. So the proximity of engineers in a clinical context, and in particular into a simulation context where we can control the circumstances and provide remarkable insights as to what's going on in the clinical world.
So these engineers and clinicians actually are together in the same room?
Oh yes, absolutely. So more and more they're creating compelling solutions by being in proximity. We've actually also very strategically brought in other components of our hospital system, like our data analytics teams and performance improvement teams, to actually work with these folks as supporting infrastructure for their ideas.
Where do the engineers and where do the clinicians come from?
So actually, primarily they're coming from the University of Illinois College of Engineering in Urbana-Champaign, but we've seen a mixture of other folks as well. We have Bradley engineers, we have folks coming from West Coast and East Coast. It's been remarkable.
Do they become employees of Jump Trading, or do they remain affiliated with their university?
So we support our employees, and a lot of the infrastructure I referred to before are OSF and Jump employees. The university doesn't need to change their employment arrangement. So the university, the faculty of the College of Engineering, they work here side by side, but they're still employees of the university.
Can you give me an example of a success that you've already had in the short time that Jump Trading has been in existence of solving a problem using this technique?
Yeah, absolutely. So, and actually, this is one of those stories that starts with the sort of the accidental, an accidental discovery. So we had purchased a three-dimensional printer to really increase our prototyping ability. So we had some engineers that were working here in our innovation laboratory, and they were using 3D modeling to build new models, new training devices, really. And one of our cardiologists came by and said, hey, that's really cool. What can we do with that? And through a process, which I'll shorten up here, we discovered that there's a great deal of value in a physical model of a child's heart for a surgeon who's about to embark on a surgery. And so by taking the clinical images from MRI and from CAT scan, we've actually been able to come up with a technique to represent in good geometry exactly what's going on inside that child's heart. Now, it's important to understand what a surgeon does when they're repairing a congenital problem, something a child's been born with. They're actually creating a mental model in their mind of how the repair will cause blood to flow through the heart in a new configuration. And that's based on their personal experience, what's in the literature, but primarily it's an art form, and they're going with it on the fly. They're creating on the fly. Wouldn't it be tremendous if we took this three-dimensional model, this physical model, and augmented it with physics, so science and math, that allow the surgeon to actually predict what their repair would look like and augment their clinical acumen?
And know that in advance.
Know it well in advance. So the answer to your question, the problem that we've solved through this technique is we've given the surgeons remarkable insights into what the repair will accomplish when it's done with the physical model. And in the future, we're looking for all kinds of advances in that modeling so that they're able to actually predict well in advance of what the surgery will accomplish.
One of the things that I'm really excited about in the Innovation Lab is that a team of our engineers have already applied for and received their first patent on a device, an educational device that they've invented. And they just were informed in January of this year that they received that patent.
And the benefit of that device might be?
Better ultrasound training.
Okay. Now, we mentioned the Affordable Care Act earlier and the impact it has on Jump Trading Simulation Education Center specifically. But has it had impact on other programs where you might be collaborating with other organizations?
Absolutely. GE and Intel have an innovation company called Care Innovations, and Care Innovations is working on creating devices and technologies to better monitor patients at home to reduce readmission rates for COPD patients or possibly diabetic patients. And in our regional transport center, we have an actual apartment that we have built for training purposes in that space, but we also use that space to do what we call usability studies around technologies, and the Care Innovations project is one of those.
So if I understand this, the Care Innovations project, is that to actually help patients at home to make sure that they're taking their medicine, that they're doing an exercise, or what? How do you check that?
Absolutely. So the usability study starts in the simulated apartment where we test teaching patients how to use these devices so that when we send the clinicians out to their home to install them, they have that training. And then those ultimately lead to clinical trials. And so now we're enrolling patients in clinical trials who have these monitoring devices in their homes. And they do things like remind them to take their medications, send us back their weight, those types of things so that a clinician can monitor them and talk to their physician if they have any concerns based on that data.
So once again, communication is key here.
Absolutely.
And you mentioned the Regional Transport Center, so let's take an opportunity to visit the Regional Transport Center. We have simulation specialist Christy Sanders and Chris Larkner to show us around.
RTC is our Regional Transport Center. We have a garage-like setting with an actual ambulance, and we have a studio furnished, fully working apartment also built there.
And you can do various scenarios for rescues in this environment?
We can. We can simulate vehicular extractions in the extrications in the garage. We can do home rescues in the apartment and any residential type rescue in our studio apartment.
What about weather conditions? Can you simulate weather conditions here?
We can. We actually have cameras set up in the garage where we could do passing traffic, maybe snowstorms or rainstorms, day and night.
And the bottom line benefit is?
It's giving the pre-hospital providers a realistic training as close as they can to what they will experience when they're actually out on an ambulance, on the streets, running calls. So they get to practice that in the environment that they will be in when they first actually treat a patient.
One aspect of the RTC training is free training on Wednesdays for emergency medical services agencies. Who's included in that, and what do they learn?
Well, there's actually a lot of agencies included, which covers pretty much the entire central Illinois region. Includes about 9 counties, about 1,600 different types and levels of providers. Every Wednesday, the Peoria EMS system, which is the system that runs most of central Illinois, They hold a free CE, which is approximately 2 hours here at the Jump Training Simulation Center, where we can do anything from scenario-based simulations or even just classroom learning.
And this is to make sure that the same protocol is followed in all of Central Illinois?
That is correct. It's either going to be, if we're in the classroom environment, we're going to be talking about different protocol changes, different things that we can be doing better. So are certain protocols not working for certain areas? Do we have to make small changes based on where somebody's working?
So for a family that is having a medical emergency at home, how do we know that this RTC training, this EMS training, is improving outcomes? What's the feedback that you get?
Well, one of the greatest feedbacks that we are getting is even for a lot of these members, most of these providers have never been through a simulation like this before. And when they come in, it's a very different, unknown for them. It's actually very intimidating. But once they come in and they go through it at least once, the first question that we always get is, are they coming back and when are they going to come back?
And bottom line for the patient is an improved outcome?
Exactly, improved outcome, and what are we doing that we can be doing better than everybody else?
Christy mentions our ability to create roadside traffic scenes. One of the things that I think people forget about when we're training first responders is that we're not just training them to take care of the patient, but also the scene itself. They have to be conscientious of other people around the scene for safety purposes, both at the roadside and in the house. So if they're taking care of a patient in a home setting, we would have a high fidelity mannequin, but we might have an actor playing the role of the spouse, and they're trained on how to deal with those social aspects as well.
Let's look at feedback so far. You've been open almost 2 years. How do you know that you're actually filling the role that you thought you would fill?
Sure. So we do surveys, obviously, of every learner that leaves, but also we get a lot of unsolicited feedback from our learners. Might be an email or a note, and some of those stories are really unique. They talk about that they were just here last week, did a simulation that involved a crisis that maybe they thought, I'll never experience this, and then the very next week they do experience it, and they're so thankful that they had that opportunity to have that learning experience. And it's not just the learner feedback, it's also proving the financial feedback as well. So one of our programs, for example, for inserting central lines in intensive care units, we've actually measured that we've reduced the length of stay for patients, which ultimately saves money, but more importantly saves lives.
We've looked at some of the programs that you offer here, but what about the future? Is there more to come yet?
Absolutely. When we talk about the Affordable Care Act and how it's changing healthcare today and the things that we're doing today, some of the things that we see coming in the future would be science of prevention. A lot of people believe that the Affordable Care Act will motivate people to take care of themselves better. And so we as a healthcare organization who are very reactive today to patients' problems are thinking about how do we get into the businesses and markets of science of prevention, keeping people healthier.
And an example, I mean, people, right now medicine is reactive and you want to be proactive and you're going to change the way people behave?
Help them change the way they behave potentially. So for example, we talked earlier about the Care Innovations Project, and so that's an example of science of prevention. That's preventing things and helping patients stay healthier longer.
Matthew Warrens, Executive Director of the Jump Training Simulation and Education Center, thank you so much for joining us on At Issue. And we'll be back next week with another edition of At Issue. We'll probably be in the studio that time.